To be here again. Thanks for having recording in progress. Thanks for having me back. Let me share my screen so that you can see what I see. Can I just make sure that you guys can all see that first slide? Awesome. Thanks for the thumbs up, Charlie. This evening's talk is called Being Triggered. So this came out of some conversations I had with Nikki, I think maybe on the call as well, listening. And because it's a concept that's becoming increasingly common, and it's one of those concepts that's kind of crept over from medical and psychiatric language, and increasingly we're seeing this kind of democratization of language that was previously kind of professional language, and for better or for worse, we don't make the rules about these words and these terms and these concepts anymore, and it can be kind of confusing for people, and people will use these ideas in different ways. And so it's helpful to kind of take a step back and think about where these ideas kind of came from, so that when we use them, we know what we mean, and we know what the kind of meaning behind them means, and we know what the potential pros are, and we know what the potential downsides or the potential harms of using certain terminology is. The risk, something that does happen in my profession, is that sometimes, to paraphrase A.E. Housman, people can use labels the way a drunk uses a lamppost, which is for support rather than illumination. So what are we going to talk about today? We'll talk a little bit about the concept of trauma and how it's evolved over the years, including with respect to post-traumatic stress disorder. And we'll talk about triggers that comes from that area. And then we'll talk a bit about how a thing called concept creep has happened over the years. This is the idea that words change meaning over time, and this is a totally normal thing to happen. And I think a lot of us try and fight that, but it's inevitable, and it's driven by social and political changes. So it's important to kind of keep up and think about those things. And then we'll think about some different viewpoints, because people have very strong feelings. People from different backgrounds have very strong feelings about these kind of ideas. So we'll just look at those different viewpoints and see what the advantages of each are. And then we'll have a think about some evidence when people have looked at the concept of triggers and trigger warnings and trauma. And we'll think also about some first principles. So I believe whenever we're thinking about our own physical and emotional health, that sometimes we turn to the evidence. So what does the evidence say? But sometimes the evidence is lacking, and so we have to think about first principles. And what I mean by that is, what are the things we know about how the mind works, about how societies work, about how relationships work, and can we kind of work up from that? So the evidence, if you like, is a sort of a top down, here's what the evidence tells us, and first principles is kind of a bottom up, here's what we know about people, and here's how we can use that knowledge to help us navigate sometimes difficult concepts. So the following episode contains content and ideas that some viewers may find upsetting. Viewer discretion is advised. We're all very familiar with seeing this kind of alert before television programs. And so the idea of seeing an advisory to tell you what's coming up is not foreign to us. My colleague at work, when I said this was my first slide, said that was a dad joke. I was referring to my own presentation for the trigger warning. And I said, well, I'm very proud of it being a dad joke. Thank you very much. So trauma and triggers. Well, the idea of trauma with respect to psychiatry and psychology dates back many, many years, and has been most studied and defined in the context of post-traumatic stress disorder. And we'll talk a second about what trauma means in the context of post-traumatic stress disorder. Trauma originally meant, so trauma comes from a German word meaning dream, and Traum. And so trauma originally meant an upsetting or distressing psychological event. It also had a separate original meaning, which was about physical trauma. So for instance, I worked in the major trauma center in Oxford, which is where people come after very serious physical injuries. So that's another sense of the word trauma. And in the previous iteration of the diagnostic classification system, trauma was defined as follows with respect to PTSD. It meant that a person experienced, witnessed, or was confronted with an event or events that involved actual or threatened death or serious injury, or a threat to the physical integrity of self or others. So this means that you were involved in or witnessed something that was life-threatening. And the person's response should have involved fear, helplessness, and horror. So that it had a, what you might call a traumatizing effect. And very commonly, after a person has been exposed to something like this, whether that's a car accident or an assault or a terrorist attack, like a close friend of mine was involved in the London Bridge attack some years ago. A very predictable consequence of that is that a person may develop an abnormally prolonged and abnormally intense set of physical and emotional responses. And that's what's called post-traumatic stress disorder. And upwards of 30% of people after a very serious trauma like this will develop post-traumatic stress disorder. And we believe that the first really nice description of this was in Samuel Pepys' diary. This is Samuel Pepys on the left, who kept a diary in the 17th century that covered such huge events in London as the Plague and the Great Fire of London. And in 1666, he personally witnessed the Great Fire of London. And he made this observation some months later. So one of the interesting things about post-traumatic stress disorder is it tends to develop over time. So it's extremely normal in the hours, days, and weeks after experiencing something traumatic to have that thing come back into your mind repeatedly. So to have vivid images of the event, vivid memories, dreams, and so on about the event. But in some people, in those 30% of people, what can happen is those vivid and distressing memories, they persist and they start to cause very marked emotional and physical reactions. So panic attacks, flashbacks, nightmares, very, very distressing experiences. And one of the things that people do to try and stop those is they try to avoid thinking about the thing. They try to avoid situations that remind them of the event, but which is seems like a perfectly sensible thing to do and a very rational, self-protective thing to do. But that process of avoidance is the thing that actually causes those experiences to get worse, and is the thing that we believe causes those experiences to persist and then to become PTSD. And PTSD, you can see the DSMs here on the right, very controversial set of books. The most recent one, DSM-5, came out a couple of years ago. But DSM-3 at the near the top there was the first time that PTSD was described. But it had been known about for many years, and in the 19th century it was called railway spine, after people who developed severe physical reactions after being involved in railway accidents. And World War I was called shell shock, and it's had different names over the years, until it became known as PTSD in around 1980 in DSM-3, and that's what we've called it ever since. And this is Samuel Pepys. Oh, am I changing slide? Oh, yes. So 6 months after the Great Fire of London, Samuel Pepys said this. I have to move my little images here. It's strange to think how to this very day I cannot sleep a night without great terrors of fire, and this very night could not sleep till almost 2 in the morning through thoughts of fire. So what's interesting about this is 6 months after he witnessed the fire, and it's also the day after he wandered around London and still saw smoke coming out of collapsed buildings, and so that was his trigger. And so the day after seeing that, he wrote this diary entry. And it's a description that will be very familiar to anyone working with people with PTSD. Oh, well, my slides have gone crazy. So these are some of the symptoms of PTSD. Very, when I've spoken with you guys before about diagnoses and using the language of disorder to describe everyone's experiences, we've talked about how sometimes that can be counterproductive. how sometimes, using all these 297 different labels we have for different disorders can cause as many problems as it solves, particularly since they're so often co-occur with each other and so on. But PTSD is a very well characterized syndrome. And these are the types of things you see. You see these intrusive memories. And what that means is you have these intrusions on your consciousness, these unwanted interruptions to your waking or sleeping function. So you get dreams, nightmares, re-experiencing, which is flashbacks, which is in response to a trigger. Sometimes you get it like a vivid reliving of the entire experience. And then other intrusions like very distressing emotional appearances, or panic, which is this intense physical threat response that is very common. The second feature is avoidance. So people with PTSD avoid thinking about the event and avoid reminders of the event, and those reminders that we call triggers. One of the really difficult things about PTSD, which can be thought of as a phobia to a memory, we'll see in a second. So all phobias are what are termed irrational fears, but actually they may be quite rational. But they are fears which are out of proportion to the actual threat of the thing. So if you have a phobia of dogs and you're around a dog that's perfectly safe, you'll get this very intense physical reaction. And that's what phobias do. They set off your body's threat response. And it can make it very difficult to function if you have a phobia of something you have to experience every day, if you have social phobia or any other kind of phobia which interferes with your daily functioning. Very difficult to have a phobia of something that lives inside your head like a memory. So it's can be an extremely difficult thing to treat. And then there are negative changes in thinking and mood. So people who are undergoing trauma don't store memories in the normal way. They store memories often in a fragmented way. So people can have difficulty recalling the event in accurate detail, and emotional numbings, and then difficult having enjoyment. And then changes in arousal and reactivity. So things like being hypervigilant all the time. That means being constantly aware, constantly aroused and looking out for threats, and sometimes things like anger and aggression as well. But the key things here are the avoidance and this phenomenon called triggers. So DSM-3, this is where this language of triggers came from in the early 1980s. That people with PTSD have these triggers that cause these intensely distressing and often overwhelming and frightening physical and emotional experiences, which then of course naturally lead to avoidance of triggers, because it makes sense that you would want to avoid that kind of experience. So from the Beck Institute, where cognitive therapy comes from, PTSD can be thought of a phobia to a memory that develops after a traumatic event. Now, the treatment for all phobias is exposure, exposure to the feared thought or the feared event. And every type of psychotherapy facilitates, helps people exposed to things that they're afraid of. It's one of the completely central things to any kind of therapy. If you're helping a person deal with the difficulties of life, the vicissitudes of life, especially if their problems are characterized by worry, fear, anxiety, and avoidance, the cure essentially for those things is to gradually, gently over time, expose them to those feared things. And you can imagine how difficult it is to safely expose somebody to a memory that's inside their head. So it can be a quite difficult disorder to treat, particularly if it's been going along for a long time. So in the trauma center where I work, we work very early with patients. So we monitor patients on a daily and then weekly basis to see if their normal experiences of distressing memories are starting to turn into that more what you might call pathological or unhelpful avoidance and intensely distressing experience cycle, and then we intervene as quickly as we can with that. But if it persists for a long time, it can be harder to treat, but not impossible. There are effective treatments, all of which involve exposure. So in the 1990s, the term trigger warning started to appear in online forums such as LiveJournal and later Tumblr. And they started to be used in conversations between women writing on blogs where they were talking about their experiences of sexual assault. And so they would say, trigger warning, you know, this post contains the following details. And I think at the time and in retrospect, this was a completely reasonable and valid thing to do, because the rates of PTSD after that kind of experience are extremely high. And so if you are in a community of people who you know that have experienced a particular type of trauma, and you want to share your story, you also want to be very sure that if a person chooses to read your story, they should know what's in it. And then when they know what's in it, they can decide A, to prepare themselves and read it, or B, they can decide not to read it. They can decide that actually that content is too distressing and overwhelming for me right now, so I choose not to read it. And so that's where the word started to appear. And you see this from Google Ngrams. You can see that the term trigger warning didn't appear in books until the kind of late 2000s, and the rate has gone up and up and up over time to 2019. So that's the origin of trigger warnings being used online. And it started to expand quite quickly from beyond those particular blogs talking about those things to related content where people would talk about self-harm, for instance, and they would say, because they were aware that if they were in a community of people who had a history of self-harm, that reading descriptions or seeing images of self-harm may cause a lot of distress for people and may even lead to people starting to self-harm again if they'd stopped, for instance. And the trigger warnings kind of expanded from there to descriptions of, for instance, abnormal eating behavior, where a person who had a history of an eating disorder might find that upsetting or triggering. And then expanded further online to descriptions of things like racially sensitive content. So if people were talking about a history of slavery, for instance, and a new experience of kind of, or a new term, racial trauma, started to enter into the lexicon as well, where people would talk about trauma as meaning multiple smaller distressing experiences over time. And we've talked about complex PTSD in the past. So in the mental health community now, there's this newer idea that where you can develop a kind of a trauma-related disorder, not just after one extraordinarily distressing and life-threatening experience, but after multiple less distressing and life-threatening experiences. So the meaning kind of spread and drifted over time and started to be used in more and more contexts. And it became controversial. So this is it. Would anyone like to guess what they think that this trigger warning is for? The following. Oh, sorry, that's the wrong one. Give me 1 second. Oh, I think this. I'm sorry, that's the wrong one. Never mind. That's not a pop quiz. That's just another example of seeing this kind of thing on TV. There will be a pop quiz in a second. So we're all very familiar with seeing these kind of alerts before television shows. So actually the idea of trigger warnings, even if they're not always called trigger warnings, are very familiar. We know that there is material that is inappropriate for children of different ages. So we're all very familiar with the BBFC classifications, some of which you can see here. And very few people, I think that those are controversial. And there are also warnings, medical warnings before some TV shows. So you all may have seen this. This is before Stranger Things. Some scenes have a strobing effect that may affect photosensitive viewers, and that's because flashing lights can induce a seizure in some people with epilepsy. So it's not unusual, and I think the concept is perfectly reasonable. I think most people would agree that if something is going to be very distressing or very inappropriate for people of a certain age, that it's a kind thing to do to alert people ahead of time. So far, so good. No controversy so far. But over the past 10 years or so, there have been changes in the meanings of some of these words and concepts, a term called concept creep. This has happened within psychiatry as well as in general discourse. So in the new version of the Diagnostic and Statistical Manual, you could now be diagnosed with PTSD if you learned that a relative or close friend was exposed to a trauma. So you don't have to be exposed to the trauma yourself. You could hear that somebody else. And this was a controversial addition. You also could have indirect exposure to details of the trauma after the fact. This is typically first responders, so police and ambulance drivers and so on. One interesting thing is that something that's culturally interesting is that the last criterion doesn't apply to exposure to traumatic things on television. So you can't be diagnosed with PTSD because you saw something on TV unless that exposure is work related. So some people may know that organizations like Facebook and Instagram hire teams of people to watch content that's been flagged by users as being abusive or traumatizing. And sometimes that can contain absolutely horrifying images of abuse, for instance. And so some people have to spend 8 hours a day watching those kind of things. And there is a new phenomenon where those people are developing quite serious psychological problems from repeated exposure to horrifying content. So the new DSM has caused this, or has led to this expansion of the term, both the term trauma, but also what it means to have been exposed to a trauma, and whether or not you can then be diagnosed with post-traumatic stress disorder. And the concept of trauma itself has expanded greatly over the years. It has moved from being a somatic description, so a description of something that happens to your body, to a description of something that happens to your mind. It's gone from meaning something extraordinary, so trauma is something unusual that most people don't experience, to something ordinary, so something that most people do experience. And as we've just seen, it's moved from meaning something direct that happened to you to something indirect, so something that you heard about a loved one experience. And there's also an idea that particularly comes from the idea of racial trauma, where it's moved from something that happens to an individual to something that happens to a whole group of people. So if your entire community is being exposed to some kind of mistreatment or discrimination or inequality, then that can refer to trauma as well. There's also been an expansion of the term harm and what harm means. So Jonathan Haidt and Greg Lukianoff, in their book, The Coddling of the American Mind, which is a really fascinating read, and is about the idea, the movement towards trying to protect children especially, but the general public generally, from harms, and whether or not that's a good thing. Because the term harm has changed over the years. Harm, we now use harm to talk about what words can do and what content can do. So there was a time when harm meant causing physical harm to people, but now harm can mean you can say something and harm them. You can say something to somebody and harm them, or you can read something that harms you, and that's actually quite a new concept. It's no longer just sticks and stones. Now all sorts of things can harm us, and for better or worse, that is an idea that is entered into public discourse. So with this spread of with this kind of creep of the meanings of these terms and the increasing use of trigger warnings in expanding contexts, of course, it's 2022, so things are controversial and people argue furiously about these things online because we've become a very divided world. Would anybody like to guess what this content warning is from? This production contains depictions of suicide, moments of violence, and references to drug use. It contains gunshot sound effects and the use of stage blood. you can put in the chat if you like. EastEnders is a great guess. It's actually Romeo and Juliet. So if you think about it, a lot of Shakespeare's plays contain pretty graphic content, but there was a big backlash from right-wing media mostly about our beloved Shakespeare and trying to protect people from the wonders and joys of great literature. And this controversy approximately fell down kind of right-left political lines, where people and more right-wing media said this is ridiculous and we shouldn't be coddling people, and people on the left said actually this is a fair and reasonable thing because people are traumatized and they have triggers, and we should and people should be informed. People should be informed when they're consuming content, and that's a fair and reasonable thing. And we'll talk about why it might fall along political lines in a second. Oops, where am I? Oh yeah, then this happened. This from an article a couple of years ago on the expanded use of trigger warnings. Another issue that's been brought up is that the word trigger might be triggering for people who've experienced gun violence. So it never ends. Nobody can agree on anything. But there's, and this is, I think this point was made slightly flippantly, but there is an interesting point here, which is that a trigger is something that definitely causes something to happen, right? A trigger on a gun is something that definitely causes something terrible to happen. That's inevitable. And I think the reasonable, so the sort of centrist position, if you like, or maybe not the centrist position, but the kind of reasoned position, when all of this kind of, disagreement and controversy is going on online, people start to think, well, if you tell somebody that there's a trigger warning, are you in effect telling them that they should be distressed, that they should be traumatized, that they won't be able to tolerate this thing? And so I think that this description was perhaps written in this slightly kind of meta jokey way, I think has a good point. And when the discussion of trigger warnings entered US college campuses, that's when the right versus left controversy reached a kind of a fever pitch. Professors were being told to put trigger warnings before their lectures. About half of people thought that was a great idea. The other half of people thought it was a terrible idea. We shouldn't be coddling our students. We should, in fact, be teaching our students to deal with difficult concepts, to be faced with ideas that they may find distressing and offensive. Rather than protecting them from them, we should be teaching them to argue with those positions and to gird themselves against an inevitably harsh and difficult world. So why this split? Well, so Jonathan Haidt, who wrote Coddling of the American Mind, has done a lot of really interesting work in a thing called moral foundations theory. And this is the idea that people lie along approximately 5 different moral axes. So people are concerned with 5 different moral areas. And one of those is the care and harm axis. And people who are more left-wing, so in America, what are called liberals, are much more concerned with the care-harm axis than are conservatives. So they're much more concerned with protecting people from harm, especially vulnerable people. Whereas conservatives, while they are concerned about this, are a little less concerned about it. And Jonathan Haidt's work has led to this really interesting finding that essentially the thing, in terms of psychological makeup, the thing that differentiates liberals from conservatives is that liberals are very concerned about fairness and they're very concerned about protecting people from harm. They're much less concerned about ideas like authority. They're much less concerned about concepts like purity. So conservatives are much more easily disgusted, for instance, by things that are kind of physically disgusting. And they're much less concerned with ideas of in-group versus out-group, us versus them. Whereas conservatives are approximately equally preoccupied with all of those things. So you can see how in a debate over whether we should be protecting people from harm or preparing people for an inevitably difficult world, you can see how there's this kind of debate. You see this being played out in a lot of the kind of Twitter controversy storms, and it's something to really understand, because if there are two groups of people whose sort of psychological makeup makes them see situations in a different way, then I think it's really important to understand the other side and to try and rise above that a little bit and to think, well, okay, we disagree, but let's think about evidence and first principles and what's the best way to proceed. So there is a little bit of evidence about this. So these three authors, Bellett, Jones, and McNally, have done quite a lot of research on this, and even they couldn't resist the temptation to put a pun in the title of their academic research paper. You can see trigger warning, empirical evidence ahead. And what they did was they did these studies of groups of students. So, you know, almost all psychological literature, you should know, is white educated college students. Difficult to generalize that to the rest of the population. And what they did was they showed in various different experiments over a few different years, in different ways, they showed upsetting content or passages of text with upsetting content to groups of students, and they told half of the groups that they gave half the group a trigger warning, and they gave the other half no warning, and they then measured afterwards how upset or traumatized people were by the content, and what they found was that when they gave people a trigger warning, that people were more likely to be upset by the content. And the proposed mechanism for that, the proposed reason for that, is that you are implicitly giving a message, like we said a second ago, that you should be upset by this, that you should find this difficult, and that you won't be able for this. That was their hypothesis. That's a reasonable hypothesis in those groups that they did it. And so their conclusion was that trigger warnings may inadvertently undermine some aspects of emotional resilience. And I propose that it's the framing of this as a trigger warning. You will be triggered is kind of the implicit message there. I should say that they did not do this on clinical populations. So they did not do this on groups of people who had been diagnosed with PTSD. They did this on groups of people who had no trauma-related diagnosis. In subsequent experiments, when they did include some people with trauma-related diagnosis, they found something interesting, which was that the groups of people who did worse with the trigger warnings were those people who had a history of trauma and who believed that their trauma formed a central part of their identity. So, and this is I think this is a trend, certainly I'm seeing clinically, and there's some evidence presented in Jonathan Haidt's book, The Coddling of the American Mind there, that over time, particularly younger populations, as they've become more fluent with the language that psychiatry uses, so the language of depression and anxiety, the language of trauma, some people have started to identify aspects of their personhood, their identity, with those disorders. And for those people, it can be more difficult to recover because they identify strongly with those very distressing experiences, experiences which may be normal experiences, but which, when the language of disorder is applied to them, can seem and feel like they are permanent and overwhelming. So there's some nuance there. I think I certainly wouldn't want to say that anybody who identifies as having a psychiatric diagnosis should not do so. Of course, there are often very good reasons to have a diagnosis and to get good treatment, but it may be the case that people who identify more with those labels are people who do find it harder to recover. So that's what the evidence, it's limited evidence, but that's what it appears to be telling us so far. This is a diagram of a lifeline in narrative exposure therapy. So this is one of the types of therapy that I'm trained in that we use to treat people who have been traumatized. And what it involves is when a person has been through a significant trauma or a series of traumas, go through a process with them where you plot out their life on a timeline like this, and then you mark off events in their life, significant events in their life, and those may be joyful events, and then separately you mark out those traumatic events. And then you go through each of those traumatic events with the person in great detail so that they're able to talk through their experience of trauma. And in a kind of a slightly metaphorical way, but this is the idea, is that you, in safely exposing the person to thinking about, remembering, and experiencing the details of those traumas, by exposing them to it in a safe way, in a trusting and safe relationship, they are then able to overcome it. Again, that's the idea of exposure. And this works extremely well. And as I said before, exposure therapy is the treatment for effectively all anxiety, all distressing psychological presentations that are characterized by anxiety. And it's often very, very effective. So this is how we treat PTSD. But of course, people who don't have PTSD aren't exactly the same. So clinical and non-clinical populations aren't perfectly analogous. So while the treatment for PTSD is exposure, first of all, you certainly wouldn't do what they used to do in the 60s, which is called flooding, which is just suddenly expose somebody to the most frightening thing. So what they used to do in the 60s was, if you're afraid of spiders, they would just sort of chuck a bucket of spiders over your head. And of course, that's incredibly traumatizing for people. We don't do that anymore, luckily. Now we do a thing called graded desensitization or graded exposure, where gradually over time, again, in that safe way, in the context of a trusting relationship, you expose a person to the feared thing. And the equivalent of the bucket of spiders for a person who's been through a very frightening ordeal is for them to be able to prepare themselves if something upsetting is coming up. And that's the purpose that trigger warnings serve. But as we can see, that the framing of trigger warnings and the way that they're presented to people may not be the best way to do it, to call them triggers, for instance. But analogous to this idea of exposure being the treatment for PTSD, a related idea is that people should be exposed to difficult things in their lifetime, and they should be taught how to manage difficult things and sit with distress and overcome adversity instead of being protected. And I think as a first principle, this is a very good and useful one. And it doesn't mean that people's distress, when they are distressed, should be undermined at all. And in fact, as you'll know from being with Talk for Health, the first step in helping anyone through anything distressing is to validate their distress, to understand that whatever they're experiencing is what they're experiencing. And then the second step is to help them overcome it. But I think it is generally true for people in the domain of psychology and in the domain of the physical world, learning to get over things that are difficult is really important. Because if we're overprotected from things that our body can handle, so injuries or difficult things that our body can handle and our mind can handle, we end up being very sick or very vulnerable. So if we're protected from difficult ideas or experiences, we may never learn how to deal with difficult ideas or experience. If we do too little exercise, our body atrophies, we die younger. If we have too little hunger, so if we eat too much, that causes illness. If we have too little stress, we don't grow as people. Too little dirt. So you've probably heard people talk about how, if kids get their hands dirty and kind of, play around in muck, that's good for the immune system. Well, actually, there's very good evidence that is the case. So in kids who grow up on farms, kids who grow up with lots of, who are allowed to kind of play in dirt and get dirty, they end up having much lower rates of asthma and autoimmune disease. And then too few peanuts I've written here as well. and there's this really interesting story that between the 1990s and the 2010s, the rates of severe peanut allergies went from 3% of the population to 17% of the population. So a massive increase. And the reason for that was because parents started to become worried that their kids would develop peanut allergies. So they stopped giving any of their kids peanuts. So over time, kids' immune systems never learned that peanuts were safe. And so they never developed, their immune systems never learned that, because your immune system learns over time. And what happened was the rate of peanut allergy shot through the roof. So there is this kind of first principle of biological systems, and we are biological systems, which is that if we try and wrap ourselves in cotton wool too much, if we try and overprotect our children too much, if we try and overprotect our bodies too much, we can end up having these really counterproductive results. And that can be really counterintuitive. I don't think this is obvious to people. There's a term, this is Nicholas Taleb here, and he gave a term to this, which is anti-fragility. So some things in the world are fragile, so they break easily. Some are resilient, which means, like a table is the example he gives. If you hit a table hard, it's fine, it's resilient, it won't break. But if you hit it hard enough, it does break, and it has a breaking point. Whereas biological systems need some variation and stress in order to stay strong. If biological systems, like people or people's minds, don't have those kind of uneven experiences, or those difficult experiences sometimes, or those changeable experiences, they don't get stronger. So you may have heard, so his analogy is that if the wind blows, it blows a candle out, but if the wind blows, it makes a fire stronger. So he said, you want to be the fire and wish for the wind. And everyone has heard this, prepare the child for the road, not the road for the child. So that's a good principle. And there are lots and lots of great quotes from history about exposure therapy and about personal growth. But I like this one by Eleanor Roosevelt, who says, "You must do the thing that you cannot do." And for a century, this is one of the guiding principles behind personal growth as understood in the context of psychotherapeutic treatments. So on the one hand, it's certainly true that those with significant trauma may be traumatized. But on the other hand, it feels like wrapping the world in cotton wool seems like a pretty bad idea, actually. And there's some evidence that overly identifying with one's label or with the language of disorder may inhibit recovery. So if we kind of try and set aside all the factional disagreement and all the squabbling on Twitter, maybe we can understand this a little bit better. Because some of these concepts are counterintuitive, and even doctors and other professionals make these types of errors all the time. If you went to see a doctor in the 1980s with back pain, the doctor was very likely to, and the back pain wasn't caused by something serious requiring surgery like a slip disc, you were very likely to have been told to rest. But nowadays, we know that it's the rest, often in chronic pain disorders, or almost always in chronic pain disorders, it's the rest which then causes muscles to get weaker, which then causes pain, which causes fear, which causes avoidance of movement, which causes weakness, and so on. So now the treatment for chronic pain conditions generally is for active rehabilitation, and again, in a safe way, but it's very analogous to this idea that in order to get over trauma, you need to be exposed gently to those things which are upsetting and traumatizing, in the same way that if you're stuck in a cycle of pain and avoidance and muscle weakness, you need to go through the same kind of a process. So a couple of takeaways and some suggestions, which are, this is my kind of take on it. Other people may have a different take, and I'd love to hear some what people think. First of all, it's a mistake to conflate the responses of a person with PTSD and other responses to content or ideas. So, the general population is not the same as people with PTSD. maybe it's best not to use the language of triggering because it has implications. And I think that the implication is, you won't be able to tolerate this. Better to use a content note, like I did at the beginning of this presentation. I said, well, here's what this is about, and you can decide yourself whether that's upsetting or not. There's nothing more helpful than saying trigger warning and then not telling anyone what's the content, because then because triggers in PTSD are very, very individual and personal. So some people, for instance, can talk about their car accident fine, and they can they can think about it fine, and that's okay. But when they smell burning rubber, for instance, or smell some other odor that's associated with the accident, they can be very triggered. So these things are very personal. So you shouldn't guess what people might be triggered by. Instead, tell them what the content of the presentation or the TV show or the article is. And instead of using the word trigger, just tell people what the content is. So exposure is the best treatment for PTSD and other anxiety problems, but it must be done in a manageable way in the context of a safe and trusting relationship. And as I said, in the same way as listening and validating distress is always the first step in helping. Overall, I think that we should foster resilience and coping rather than protect everyone from everything. And if you're writing an article or making a TV show, your job is not to protect the world from the content. I think is to advise people what's in it. If they choose to avoid it, they can do so. And I think it's just important to say that that's all completely different to exposure to like gratuitously distressing content. So, like really nasty and unpleasant violence or content that's inappropriate for children. I think that's I don't want people to get the idea that I'm suggesting that is a good thing. So that's where we have it, I think. So if anybody has any questions, I think that John may have been looking at some of the questions in the chat and might have a digest for me.
Yeah, Ian, Mike has actually been doing that, so he's been
Mike is doing that
as we go. But really happy that you open up the questions to the floor if people want to use the reactions and put their hand up. If you're happy to take questions from the group as well, that would be great.
Sure.
Yeah, I'm just going to share my screen so you can see the questions that were asked. I've just been keeping a track of them. So here's a kind of a log of questions you can see. I don't know if that's very helpful.
Yeah. Oh yeah, great, that's right. So first one is how to trigger warn without spoilers. So as I said, I wouldn't call it trigger warning because there is that implication of something inevitable and kind of, I think, maybe fostering fragility. How to do without spoilers? Well, it's difficult if you're if your key plot point is the only thing that has a spoiler in it. But I think that usually you can describe things in kind of general enough terms. The second question, the graph liberals for conservatives comes from the work of Jonathan Haidt, and you can see if you look up moral foundations theory, they have a website which I think is called moralfoundations.org, and you can also there's a good Wikipedia article that describes that, and the book that's a great read, which is all about that. It's called The Righteous Mind if people are interested. And the next question, can you suggest a reading list? So I would suggest for a kind of a middle of the road sort of view, I would suggest those two books by Jonathan Haidt. So one is The Coddling of the American Mind, the other is The Righteous Mind. They're really great books. They're quite academic, but actually they're really very readable. There are also a handful of very good articles, one from BuzzFeed, one on Vox.com, and one from New York Magazine about trigger warnings. That if you type in trigger warning and New York Mag, NY Mag, Vox.com, and BuzzFeed, there's some really nice balanced articles there, which I think do a lot of this. They go into some more detail on some aspects than I did, and they cover some different areas. But there's a nice balance of saying, this is a difficult area. People are triggered. That we have a different understanding of what those things mean now. But also, they also do allude to this idea that actually kind of overall, what we should be doing is saying to people, there are some difficult things ahead, so you can prepare yourself, but it's best to, engage with things that are difficult and upsetting so that you can, learn how to do that. Presumably there will be ethical issues with researching on traumatized populations. Yeah, for sure. So that's why that early research on trigger warnings wasn't done on populations of PTSD, for instance. Yeah, so you'll be very careful, and that might be a difficult one to get ethical approval for. The next one, with Harry Potter books now carrying trigger warnings, how do we as a society strike the right balance to ensure resilient communities, but at the same time ensure no harms? Yeah, I did see an article this morning about Harry Potter and trigger warnings. I didn't read it, so I don't actually know what that's about in detail, but I think the right balance, I think that in your question, it says ensure no harms. And I don't think we can ensure no harms. And I don't think that we should ensure no harms. I think a harm is inevitable. And so I think that we should do both. We should ensure resilient communities and try not to do gratuitous harm. But I don't think that it's anybody's job to protect the world from these kind of inevitable harms and upsetting things that they may see or hear. Again, with the exception of things obviously that are inappropriate for kids, or things that things that aren't age appropriate. So yeah, I think we can ensure no harms. I think it's much better to, as they say, prepare the child for the road rather than the road for the child. Ella says, I am aware of a different reason for a drastic increase in severe allergies at that time in the West, but no more detail there. Certainly true that there are multifactorial causes for allergies, and Ella may be referring to the increase in pollution, for instance, which is absolutely right. Increase of asthma, a lot of that caused by pollution and climate change, causing really severe respiratory illnesses worldwide. But in studies where those things are controlled for, there is this still association between exposure to bacteria and viruses, and then subsequent stronger immune systems. Or if not stronger immune systems, different profile of kind of immune disorders. Next one, I'm wondering how distressed post-exposure was measured. If it's a self-measure or a subjective scale, maybe it's simply that people shown a trigger warning feel more confident expressing their distress afterwards. Are there objective measures of distress, or is distress level always subjective? So this is a great question. Distress is always subjective. Emotional distress. You can make assumptions or you can make guesses about people's level of distress by observing them, for instance, by looking at a person's face, as sometimes you can tell. You can also, increasingly people are interested in doing this by passive measurement of things like heart rate variability, skin conductance, so how much you sweat and things like that. The problem with all of those measures, I think, is that the only way to tell if someone's distressed is to ask them if there's distressed. So while you make a great point that a subjective measure is always flawed because it's reliant on self-report, the best way of telling if somebody is distressed is to say, are you distressed? But it's a great point. Next question is, where does attachment theory fit in? A secure attachment equals greater resilience, insecure or ambivalent, less resilience. Yeah, so I think attachment theory is a fantastically useful way of understanding how people are, especially in relationships, and it's often related to our experiences and upbringing. And certainly, in a given individual, you can certainly make guesses about trauma, which is often associated with attachment styles that may be less helpful and make a person less able to deal with distress and less able to deal with the kind of inevitable ups and downs of life. So certainly there's a relationship there. and I think they're kind of just two different ways of understanding people's experience. But of course, we need loads and loads of different ways to understand people's experience because people are really complex. So I think it's another great one to think of, and it's one that I use a lot in my work. We were very lucky to have Peter Fonagy come and speak to us recently, and he's one of the fathers of attachment theory. And I love that you've put in Viktor Frankl there. Next comment, should perhaps terms like trigger or triggering be reclaimed by the healthcare profession and not used in everyday language? Well, I think with all of these things, the cat is out of the bag. Pandora's box is open. These words are now part of the general lexicon, and there's no way back from that. Professionals sometimes kind of hide behind language. And that's a bad thing. But then sometimes when that language gets co-opted and maybe misunderstood, that can be a bad thing as well. But one way or another, whether for ill or for good, it's happened now, and it's part of the general language, and people will use it in different ways. And it will continue to change and morph over time, and people will continue to argue over what the language means. But no, I don't think anybody has any control over that. That it's an organic process that goes on. So that's I think that's where we're at, really. Trauma was described earlier, but did not include epigenetic trauma. How is this considered? So epigenetics, for anybody who doesn't know, describes things that may be transmitted from generation to generation that isn't part of the core DNA, so isn't part of your genetic code. And it's a pretty speculative area at the moment, both in physical illness, but also in things like transgenerational transmission of trauma. A lot of people think that it is likely to explain some of the transmission of trauma from generation to generation. Both physical trauma, like, so for instance, populations that go through famine, but also psychological trauma like mistreatment or abuse, and the effect that has on the body. But I think that I just spoke to an epigenetic specialist about this recently. I just think that we just don't know actually what the magnitude of that effect is at the moment, or whether indeed there is a meaningful effect. Next comment. It's all very well and good not coddling people if they have support to engage with triggers or difficult issues in the graded way you describe, but what if they don't? Many barriers to emotional and psychological support, we cannot assume everyone is supported. And that's absolutely right and absolutely true. Not everybody has the support system around them. Not everybody has been through an upbringing where they are taught the tools to deal with things that are difficult and problematic. So I don't at all suggest that we tell those people that, or tell anyone that they're being coddled. But I think to have the idea in the kind of general population, to have this sort of social awareness that the best way for people to deal with things that are difficult is not to avoid them all the time, but to learn ways to manage them. I just think that's an important concept. But I completely take your point, and I'd hate to give the idea that I was saying, let's just kind of harm everyone with upsetting things and let the chips fall where they may. That certainly wasn't what I meant. Next, how are we for time? Like, go on and do a couple of more.
We've got plenty of time, Ian. In fact, if you'd like to take some live questions from the room, if people put their hands up, we can ask them questions. So we've got plenty of time.
Sure. Yeah. Does anybody want to unmute? And if we can just go, maybe we don't need to screen share anymore. We can just, people in the audience can.
And if you raise your hand, just raise your hand, and we'll take you in the order that you come. So, any questions for Ian? So, we have Sarish.
Hello, Ian. First of all, I wanted to say that was very informative and very eloquently put, and actually quite easy to follow. So thank you for that. Very interesting. My question is more, I think people have asked the question, but I think it's, where do we draw the line? So I work with young people as well as adults. and with language, I do think I actually recently done the Talk for Health program as well, and I think how you word things is so important. But it's kind of like, where do you draw the line with language, such like you said, trigger warning? An adult maybe kind of have more of an understanding of what that means. With a young person, I wouldn't say a child, but like a late teens, early adulthood, kind of their understanding. It's about understanding. So you can use certain language, I believe, but it was also the understanding of how someone interprets that language. And I just think it's a bit difficult to sometimes know where to draw the line. I have found I am actually struggling with kind of terminology and the right things to say. It's quite difficult to assess kind of which language to use, what would be okay. And actually, how far is mollycoddling? Are we kind of censoring everything?
Yeah, sure. Yeah. I think that the trouble with jargon is that people understand it in different ways. So I know, for instance, that like when I say anxiety, I mean something really specific. I mean, you know, the worry that something bad is going to happen in the future. But I know from speaking to patients and speaking to parents that they have completely different understandings of what anxiety means. So I have, and one of the problems with jargon is particularly when it spills over from kind of professional usage into lay usage, is that it can be understood in lots of different ways. So I tend to not use any of that jargon. I tend to try, and as much as I can, to just describe the thing that I'm talking about rather than to use those kind of label-y terms. I think that you might have been talking about something slightly different, which is like, or maybe if you could give me an example of like
I think what you just said is, I think my question wasn't very clear because I was trying to put everything together, but I think what you just said was quite clear in the sense, you know, nowadays people use the term OCD so like blasé, and I think I've actually started to use that approach where if someone says they're feeling something, my question is, okay, how are you feeling? As opposed to them telling me, because they could say they have OCD, but they just may be a bit meticulously put things. And OCD is an actual condition, for example. I think the social media era has made things a bit more relaxed of how we use terms. And also, I think it's taken the value away from some of the terminology that is used. And that is my concern, because when you speak to a young person, and I say this from my own experience when I'm talking to people, they're having a down day and they've now got in their head they're depressed, which then kind of they start to look at what symptoms of depression are, and I've actually found can actually fall into that where they originally weren't feeling medically depressed, but then they start to look at symptoms, they discuss it, and they start to kind of follow on to that. I know that sounds a bit harsh, but I've actually seen that in my own, where it's so casually put now, and things like depressed and OCD and anxiety, like you just said, I think it's better to kind of ask, how do you feel anxious, as opposed to, or then just saying you've definitely got anxiety. I think people then read into those and kind of, it's like self-diagnosing a lot, which I think is also dangerous. I have anxiety, or you may just feel anxious. We all feel anxious on a day-to-day basis, which is very different from having anxiety as a condition. Am I correct in saying that?
Oh yeah, 100%. So, and it's interesting when a person says to me, I have anxiety, I think that the way I follow that up is to say, oh, that's, you know, that's, can you tell me exactly what you mean when you say that? Because I think most people, when they say I have anxiety, they mean I am anxious. But it's funny how it's become this thing that you have rather than an experience that happens to you, which is a completely normal and expected part of life. And that kind of subtle quirk of language, I think changes the sort of relationship with anxiety and the ownership in a way that is potentially unhelpful. And as you've pointed out, the language, you have to be careful about your use of language. And I think I made a mistake. I mean, the term coddling is not mine, it's in the title of that book, but I think that when I use that term, it is a term that sounds really kind of invalidating, right? And so I think I was possibly wasn't cautious enough in using that term, because it's not actually what I mean. What I mean is, you know, we protect people when it's appropriate, but we allow people to experience things that are difficult, to learn how to experience things that are difficult. Yeah, it's a tough one.
Yeah, it is. I mean, I'm learning as I go along. That's why I just wanted to know kind of more from your perspective. And I think it's great that you took ownership of it. You said, actually, that's not my term. Because I do that when I discuss things. Sometimes I have to check myself and say, right, I can't say I assume, or I can't say I think, you know, the way I'm saying things, it can change the whole conversation. And also taking ownership. It's like, you know, previously, when I first was diagnosed with a mental health condition myself, I'd be like, I have borderline personality disorder. And I've started using the term, actually, I live with borderline personality disorder. It's not it doesn't define me as a person. It's just part of who I am. And I think ownership, I just want to thank you on that part. I think ownership is definitely part of my journey and something I really want to promote. Generally, you know, it's not who you are, it's just a part of you. It doesn't define you. It's just a part of your experience. The trauma or anything you go through is your experience. It's not you as a whole person. So thank you for that. Actually, I like that you put that in there.
Great, thank you. I'm gonna let you guys. Yeah, I see that we're just after 9:15, so I'm gonna let you guys get on with your.
Iain, we've got plenty of time, and there's a couple more questions. So if you're happy to continue on, we'll take them on.
Let's take one last one.
Okay, well, I've got two. Can we take two? One from Catherine and one from Chiara. So Catherine.
Yeah, mine is just really about when we talk about PTSD and triggers, do we differentiate between like a sensory trigger, like smelling fire, for example, or hearing a sound, and like a linguistic trigger, like if you're reading a post on Facebook and seeing a word that might trigger an experience that you've had, like in research or when you're supporting people, like is it important to differentiate between sensory triggers and like linguistic triggers, if that's the term?
Sure. I would say that you know, what brings on a person's symptoms brings on a person's symptoms, and some people that may be a smell, or it may be getting in a car, or it may be a person driving too fast, or it may be a loud noise. So there isn't a reason that immediately comes to mind why I would distinguish between those generally, unless it were just to know that for a particular person, a particular trigger, so that I could then either alert them to it, or I could, you know, be careful to avoid it. So, for instance, I think particularly, you know, if somebody has, you know, there obviously are cases where you would say, well, exposing this person to this content or this situation at this time in their recovery journey is not the right thing to do. So in the sense that knowing what a trigger is for a particular person is important, but I can't think of another reason to distinguish them, if you like.
Thank you.
Okay, Chiara.
Thank you. Thanks so much, Iain. That was fascinating, really, really interesting. So my question is, I'm trying to think about how to phrase it, but I feel like maybe nowadays people are more comfortable expressing their emotional distress. And so I wondered whether it's almost that effect of people responding more to trigger, or I don't know, or maybe, okay, my question is, in like a long-term psychological well-being, do we know, you know, is it better? So if people are doing more of expressing their emotional distress rather than just more of being distressed, can you talk to that a little bit?
Sure. So a super easy question for the last one. Yeah, wow, there's a lot there. So I think generally speaking, that people communicate their emotional state and their needs more now is overall a good thing, right? That might sound super obvious, right? You know, that perhaps there are some people who might do it less, and that might serve them well. But for most people, I think being able to be vulnerable, being able to communicate their needs is a good thing. You know, to be able to tell a person how you're feeling, particularly a loved one, to be able to talk and think about how life is affecting you, and to be able to take steps to improve things, all require an ability to talk about distress and to talk about emotions. And I'm sure you're right that the fact that that is how society is changing, at least in the English-speaking world, is, I'm sure, related to the fact that people are now more comfortable talking about the fact that they found a particular thing upsetting, or has reminded them of an abusive situation, and so on. And certainly there are these huge movements now where people are encouraged to talk. The one difficulty I think with that is, for instance, telling men to talk about their emotions more is all well and good, as long as they have somebody to talk to, or as long as they have people to talk to who won't ridicule them or stigmatize them for having talked about those things. So I think that's the one drawback potentially with a blanket advice to kind of always to talk about your emotions more. But generally speaking, yeah, being in touch with knowing ourselves and being in touch with our emotional states is an almost unalloyed good. And I'm sure you're right that it's led to an increase in a kind of a discourse like this that some people don't like and aren't comfortable with, and that's probably another source of division between Group A and Group B. So yeah, but great question. Okay, I could talk about that for the next 2 hours. Thanks everybody for amazing questions and a really great discussion. I look forward to seeing you guys at the next event.
Yeah. Iain, that was fascinating, and we really do appreciate you coming on and talking to Talk for Health and our community. And as you say, we could talk all evening. So really appreciate that. So we're just going to take a 5-minute break, and then we'll come back and we'll just move into a co-listening exercise, just so that people can get a chance to talk about what they've heard or their own experiences. So if I can ask you all to come back at 7:28, we will restart with a co-listening exercise. Okay, so just take 5 minutes just to move away from the screen, get a little bit of movement, maybe a drink, and I'll see you at 7:28.